everyone. Welcome to our annual BabyChecker webinar. Our theme today is Leapfrogging Maternal Health Challenges, AI-enabled innovation for equitable health access in low and middle-income countries. My name is Katyayini, and I'm delighted to host you today. Today, my colleagues and I will be joined by experts from Zambia, Kenya, and Sierra Leone to discuss how AI-enabled solutions can strengthen maternal and antenatal healthcare in low-resource settings. Our speakers will talk about the challenges they face on the ground and how AI solutions like BabyChecker can and are moving beyond immediate fixes and playing a role in sustainable, long-term improvements in maternal and antenatal health in low and middle-income countries. Before we begin, a few quick notes to all our audiences. This webinar is being simultaneously interpreted into French, Spanish, and Urdu. So please ensure that you are on the right channel. Also, in case you have any questions during the presentations, please remember to put your questions in the Q&A section, where our experts and my colleagues will answer in the end of the webinar. To kick off our discussion, I'm pleased to introduce our first speaker, my managing director, Florent Geerts. Today, he will discuss how we as an organization are innovating for equitable health. Florent, the floor is yours.
Thank you, Katya, for the introduction, and a very good morning and afternoon for everybody who has dialed in. Today, I'll start by giving you a first introduction to Delft Imaging as an organization before we dive into talking more about BabyChecker specifically. You can go to the next slide, please. Yeah, perfect. Yes, perfect. One more. So to give you a little bit of a background of where we come from as an organization, for those of you that might not be that familiar with us yet, our organization actually goes back to the beginning of the early 20th century, where we were always involved in X-ray imaging and specifically specialized in tuberculosis screening. And this is something that we did with analog X-ray and then with these little mobile clinics. You can see our brand name here on the side. And over the years, actually, our technology has evolved to digital X-ray and also working with artificial intelligence rather than with human readers. But our approach has remained the same. And when we supported TB screening actually in the 70s of the previous century across Europe, and then when we eradicated it largely across Europe, we moved to those countries where TB is still a burden today. And that brings us to many countries around the world, especially in LMIC settings. So I just want to give you a little bit of an idea where we come from with the specialism in tuberculosis screening, also leveraging tools like AI, and how later that expanded into the work we're doing with BabyChecker today. Next slide, please. So I think important to note from our side, Delft Imaging is a social enterprise, which means that we are a private organization, but we're very much focused on making an impact first. So one of the things in our approach is that we always try to see, okay, what is the problem specifically in a healthcare setting in which we really can make a difference? And then we trust that we are creative enough to ensure that there's a way to make that profitable and thereby also sustainable over time. So we're also a part of the Million Lives Collective, which recognizes innovations that have impacted more than 1 million lives around the world, part of the United Nations Global Compact, and also certified B Corp for the past 4 to 5 years. So one of the things we always do as an organization is that every year we bring out an annual impact report in which people can also transparently read more about how we've performed that year, things we've been working on, and that is both on the BabyChecker side as well as on our different solutions that we have. Next slide, please. So our presence, and actually coming back to also what we do with tuberculosis screening, also the work we do with BabyChecker, has brought our activities to more than 85 countries around the world, which you see visualized here. And as you can see, those are largely and almost solely LMIC settings, so low middle income countries. And this really comes out of that focus being focused on TB and also on the detection of risky pregnancies in low resource settings. Here in orange, you can see our own offices, like our headquarters in the Netherlands, where we are based today, our office in Ghana, Nigeria, and Indonesia. And you have a bit of an idea of the activities or places where we are active. As you can see, we virtually don't run any projects in Europe, even though our headquarters is in the Netherlands or in the US, because we really specialize in those health problems that are present in the global south. So over the years, we've been able to impact the lives of more than 30 million people around the world with our different solutions, using both imaging on the hardware side, like X-ray and ultrasound, and also using AI. Next slide, please. So one of the things I wanted to mention, and before we really dive into BabyChecker, I think this gives you a bit of an idea of our approach to how we work, is that we really try to be a one-stop solution for the health problems that we aim to tackle. So we really try to bring hardware, so the imaging side, so it could be digital x-rays, like we see here an example of what we do on TB screening and mobile clinics, but could also be with ultrasound, for example, with the software, like the CAT software for TB, but also with using BabyChecker. And we combine that with training and e-learning and various means of capacity building, and also with after sales and service, so that we can be holistically a partner for those organizations that are implementing these projects around the world and really provide all of the requested solutions A to Z. So the hardware, the software, all of the logistics around it, and also the capacity building and the service to ensure that things can be used sustainably. Next slide, please. Yeah, next slide. So, of course, we're talking really today about AI for the detection of risky pregnancies, but I did want to touch upon this quite briefly. So one of the things we're doing a lot of work on in the TB sphere is actually really with portable digital x-rays. And I won't go all over the bullet points that are here, but one of the things that I find interesting is that what we've been able to do is using these portable backpack x-rays with the combination of AI. We have these x-ray systems that can go even into the most remote settings of a country and be able to take 400 x-ray images there. And they're quite portable. They weigh less than 30 kilos. So you can bring them on a keke, on a 4x4, even on a boat if you wanted to. And I think this combination of having both the hardware side that is very portable, and on the CAT side, where we can support with, rather than having human readers, in every remote corner of the world, which wouldn't be feasible, we have CAT and AI to help out with the interpretation of, well, could be TB, but also, for example, of identification of risk factors during pregnancy. If you go to the next slide. Because this is what we've really been able to do on the TB side. So we're very most known for the CAT for TB software, actually, that we've developed over time. And this is actually something that started with research already in 1996. So there's a whole category that's today quite popular as AI for TB. It's actually something that was founded by us 20 years ago. And we started with projects already in 2007 on this, received the CE certification in 2015. And by 2018, we were already screening more than 1 million people per year using AI for TB specifically. 2021, because of all of that validation and projects that we had worked on, the World Health Organization endorsed AI for TB screening. And back then, we already had about 700 installations in nearly 60 countries. Today, it's one of the best performing algorithms available and active in more than 85 countries and has screened more than 30 million people and has been featured in more than 100 publications. So the way that it works is that it gives you a score between 0 and 100, indicating the extent of TB, as well as a color-coded heat map to show where those abnormalities are located. And I wanted to highlight these examples specifically because what we're doing, and I'll talk a little bit more about that in a second, is that like what we're doing on BabyChecker, again, we're combining both the hardware and the CAT AI software to be able to tackle these health problems in even the most remote corners of the world. Next slide, please. Yeah, so if you look at these, if you click, so just various examples of the software being used around the world. And we've actually had now a similar trajectory, and the team will talk about more about what we've been doing, of course, with BabyChecker, but starting with research, being able to roll out initial projects with partners, scaling up both in validation and in projects to really now where it's a solution that's been scaling up quite rapidly across the world and really having a real life clinical impact in those areas where it's needed the most. Next slide, please. One of the things I also briefly wanted to mention is that we're doing a lot of research currently also using ultrasound and AI for lung health. And this is actually something that we build upon the experience that we have with BabyChecker, using both a handheld ultrasound and on top of that, an AI to help control the sweeps that people have to make. And then working with artificial intelligence to basically identify potential abnormalities in the lung. So there's actually a new area of research after BabyChecker that leverages experience that we've used in that field, that we're actually now doing a lot of research in and that we see as an interesting area towards the future. Next slide, please. Yeah, of course, the team will talk about this much more, but I just wanted to give this as a bit of an introduction to how we work as a company. So we've built a lot of this experience in tuberculosis screening around the world, and then moved from AI for TB to AI for pregnancy-related risks. And that is because we saw that every day more than 800 women die from preventable pregnancy-related causes. The majority of these, the far majority, are in low and middle-income countries. And from the way that we approach it is that we believe that a problem that is this extensively present in LMIC settings really requires a solution that's designed and developed for LMIC settings, taking into account infrastructural context, taking into account all of the opportunities and the challenges that LMIC have to deal with on a daily basis. So rather than taking, an ultrasound solution that we would have in a hospital here, really developing and implementing a solution that really is designed for those places that face most of this health burden. And that is how we came up eventually based on this problem with BabyChecker. So it's an artificial intelligence solution that analyzes obstetric ultrasounds to identify potential risks during pregnancy. So again, really a turnkey solution that's tailored to local settings and challenges. Turnkey meaning that, like what we do on TB, combining both the hardware, the software, being able to do the capacity building in person or remote, and also the required after sales support to ensure that these projects can run continuously for many years to come. So what we're really been doing is to bring Delft's expertise and experience as a total solution provider in this sphere, working on both the hardware side, like the low-cost ultrasound in this case, providing the phone with the app on it, as well as the AI software, and combining capacity building and service all under one roof. And we're really bringing that experience that we have on TB with all of those partners across the world and leveraging that now into this new, relatively new area of AI for pregnancy-related risks. So I just wanted to give that as a short introduction to how we work as an organization, where we're coming from, and the experience that we've built in TB and that we're bringing into this space. I hope that you find the rest of the webinars and our speakers useful today, and that it gives you some useful insight. Thank you, everyone.
Thanks, Florent. As he pointed out, equitable health is the cornerstone of all our innovations here at Delft. To further elaborate on this, I'd like to invite my colleague, Enya Seguin, who will explain how BabyChecker is assisting in maternal and antenatal health in her presentation, BabyChecker AI for Pregnancy Screening. Enya, the floor is yours.
Hi, everyone. Thank you so much for coming to our webinar. I see a lot of familiar names in the attendee list from our partners, clients, upcoming partners as well that we're planning some research projects with, from Kenya to Sierra Leone to Nigeria to Senegal and everything in between, also some bits of Southern Africa. We have 98 attendees, and it keeps on coming. So I'm really excited to see some familiar names. So my role in this webinar is largely to just draw the picture of what we've done with BabyChecker in the past couple of years and kind of set the scene, as a nice segue from Florent's presentation on what Delft imaging is, what our sort of ethos is towards developing high-tech solutions for the lowest resource settings and making sure that they are scalable, that they're implemented with local partners, and to continue innovating to really tackle these diseases and complications that have still a very high burden in LMICs. So when we started building BabyChecker about 6 years ago, it was really a no-brainer for a social enterprise like Delft Imaging to really dive into this. Our company always makes sure that we're building medical imaging technologies to reach the hardest to reach communities. We've pioneered in computer-aided detection and artificial intelligence for medical imaging, and we always have an emphasis on the importance of local partnerships. We also have a strong emphasis on measuring our impact. We have an impact report every year. So all of these sort of 4 points is really what builds the foundation to what our social enterprise is and does. So it's not just things that we plan, but things that we really put into action to everything we do. And towards then Delft Imaging expanding itself into the maternal newborn health sector with BabyChecker, we started building BabyChecker with a few points of knowledge, points that many of you in the attendees list already know a lot about, right? It's the fact that a woman dies every 2 minutes from pregnancy and childbirth, and that 95% of those deaths are actually happening in LMICs, and they are largely preventable. What we also know is that ultrasound is critical in pregnancy screening. There's a reason why WHO recommends ultrasounds when you're pregnant. There's a reason why many women, especially in the Western world, will get multiple ultrasound scans throughout their pregnancy. But we know that only 2/3 of women actually don't have access to any ultrasound scanning during their pregnancy. And I know a lot of you who work in the sector will know this by working in community health centers where women are, having a lot of babies, and they're maybe on their 5th or their even 10th pregnancy, and they've never had an ultrasound scan. So this is something that really statistics and, being on site and having that sort of knowledge really coincides together. What we also know, towards building what BabyChecker is that it's really important to invest in primary healthcare, especially in LMICs, where we need more early detection, we need more timely referrals, and we need to reduce the inequities in health access. So that's how we built BabyChecker, is with the foundation of what Florent and I just mentioned about how Delft operates and the sort of mindset that we have towards addressing high burden diseases and complications through medical imaging and through artificial intelligence. And so what we set out to do with BabyChecker is really to empower frontline healthcare workers who are a pillar of making health access equitable, especially in LMICs. And so the creation of BabyChecker, even though, as you all know, has artificial intelligence as its heart, as the true heart of the solution, actually is surrounded by many other critical components that make it what it is today. For example, we have a mobile app. So of course, what BabyChecker is artificial intelligence that analyzes obstetric scans to identify risky pregnancies. How it's seen is it's a phone that a probe can connect to, right? So it's really important that not just the AI works on the phone, but that the app that basically surrounds the AI, if you will, is easy to understand and can be easily understood by a healthcare worker like Monica or Katyayini in the picture you see, who have never used a smartphone before, can find it easy to use BabyChecker. Another very critical component of BabyChecker beyond the AI has been the training video. So as many of you know, we built a solution that is easily scalable because there is no on-site training required. And I know for many of us that work in the fields of health programs, health interventions, even digital health interventions, there's always quite a hefty and usually very expensive training bit in the budgeting, right? And so we really try to reduce that to a minimum. So what we have now is a 3-minute training video, which one of our speakers will talk about as well, since she focused her research on assessing the usability of BabyChecker as a result of that training video. And it's been really important in the past years to make sure that that video is the only training that a frontline healthcare worker needs to use BabyChecker. Another bit that seems quite more minimal than the app or the training or the AI is the bag. So some of you I see in the participants list have a BabyChecker or a few BabyCheckers, and you know how it comes. It comes in a beautiful orange or purple case. And it's been really important to make sure that that's part of the product as well, because a lot of our midwives and nurses using BabyChecker are actually going on outreaches, and they're going into women's homes, into the community with BabyChecker. And it's been really important that they enjoy carrying it, right? So beyond building a validated and growing artificial intelligence, which you will hear more about by my colleague Julio, who's leading that, it's been important to build a solution that is easy to use and that our end users actually enjoy. And that's something that often is not spoken about at large. We focus a lot on AI, and that term has been everywhere, especially in the past year. So my main point here was really to kind of zoom out of AI for a little bit, even though AI is part of our webinar title, to really, cast some light on the importance of other aspects that surround the AI, that make it more human, that make it more palatable, usable, and also reflective, in a sense that we as a company in building BabyChecker into what it is today have always been very receptive to what users have to say and what their opinions have been on the product since it was a prototype. And of course, how you get that sort of feedback is based on years of relationship building and trust building in the communities. So Julio and I actually just got back from Sierra Leone yesterday, where we have our longest running research project. And so that research project, especially amongst many others, has been really key in building this product because of those years of relationship building with the end users, with midwives, traditional birth attendants, CHWs, etc., to really know more about whether they enjoy using BabyChecker, whether they can use BabyChecker, so optimizing the training and the app to make sure that they can use it, and also whether it empowers them and helps them do their job, which is already so important and so packed with so many things. So many of these health workers are out on training, once a month.
Sure here and there. Enya gets online. Enya, can you hear us?
Yes.
Can
you hear me?
Yeah, I can. Okay, I can hear you now. Thanks.
Perfect. So where I left off, I hope, was about our receptive product development method, which has really been used on or been built on the cycles of hearing user feedback, like all the people you see in the picture right now, which is of course just a snippet. It's from Zambia to Tanzania to Kenya to Sierra Leone. All the pictures you see right now have really, these users have really formed what BabyChecker is today. And of course, our technological innovations would never reach the intended beneficiaries if it wasn't for our partners. So from our research partners like KIT, the Royal Tropical Institute in the Netherlands, to Radboud UMC here in the Netherlands as well, Lionheart Medical Center, the District Health Office in Tonkolili, Sierra Leone, amongst many others, and our suppliers, of course, Fairphone, Telemed, and all the other organizations, and of course, our partners and the early adopters and clients of BabyChecker that have made this possible and have continued to help us improve BabyChecker from the point that it is today. So I will close my presentation here, and I just want to say, thank you very much for attending this webinar, and thank you for our speakers, which you will hear about very soon. I've met all of them in the past couple of years, and they all have played significant and different roles towards BabyChecker, from being a sort of early adopter and putting the BabyChecker into mobile clinics, to researching usability and implementing BabyChecker in public health facilities in Kenya, which you will hear a lot more about in a second. So thank you very much.
Thank you so much, Enya. like she pointed out, it's extremely important to remember the human side of this as well. AI by itself is nothing if you don't count in the people who make it work. On that note, before I move into the next speaker, I just want to kindly remind all our viewers today that if you have any questions about any of the upcoming presentations, please make sure that you put your questions in the Q&A section so that our experts can answer it at the end of the webinar. Okay, now I'd like to invite Tafadzwa Kalisto Munzwa, the co-founder and the executive director of Dawa Health in Zambia. Today, he will be talking about the preliminary finding on AI-driven non-invasive anemia detection using a smartphone application. Welcome, Tafadzwa.
Thank you for having me, Katya. And good afternoon, good morning, everyone, depending where you're calling me from. Yeah, I think I can just go on into how we've been using BabyChecker really in our mobile clinics and now also in slum communities where we still have a lot of challenges with regards to accessibility of diagnostic technology and how we really have been leveraging AI, including BabyChecker and other tools we have incorporated in our work and research as well. Next slide, please. Yeah, okay. Dawa Health is a company we started about 4 years back now. And the initial spark to the work we are doing now was my cousin at the time. So you can see that in low and middle income countries, this problem is really non-selective in who it affects. So my cousin at the time had a bit of pregnancy complications, which eventually resolved her, and her baby and herself were eventually stable. But that was the initial spark. And with my background training, which is medicine, I started really thinking around how could we use technology and innovative ways to reach more patients or more people like my cousin and to make a difference in their lives. So we have built that over the years and we've incorporated and evolved over time, which I'll briefly talk about, and also the tools we're using at the moment. Next slide, please. So this is a big problem or colossal challenge I decided to dedicate my life to, which is reducing maternal mortality in sub-Saharan Africa. So if you look globally, about 70% of the daily maternal mortality in the world happens in low and middle income countries, and sub-Saharan Africa is massively affected with that. So this is just a comparative analysis of, you can see the maternal mortality per 100,000 women across sub-Saharan Africa and across Europe. You can see, the significant difference that more than 533 mothers are dying, from preventable pregnancy complications in sub-Saharan Africa compared to just about 6 in Europe, which really emphasizes on finding innovative ways that can make a difference in life-saving going forward across our region, with what's been done before, not really solving it to the extent we want it to. Next slide, please. So this is the current state of maternal health in Zambia. And like I mentioned, about 70% of maternal mortality is still in sub-Saharan Africa. And in the markets we are working in right now across Zambia and Zimbabwe, you see that about 15 mothers are dying daily from preventable pregnancy complications, which is totally unacceptable. That someone would die from, example, postpartum hemorrhage, which could have been prevented with the right screening tools, which I think BabyChecker does to a significant extent, and some of the tools we are doing. And another challenge we got to see in these communities we are working in is that most patients or most mothers present for antenatal pretty late. So they're usually coming in the second trimester around the 5th or the 6th month, which is usually later than we want them to. As health workers, we want a mother to come in the first trimester because that's when you can significantly make a difference and advise them or do the necessary interventions to prevent a complication setting in. And from what we were doing early on, maybe from the last 2 years, we got to see that even though about 40% of the patients receive antenatal, it's still not significant enough. And I think like what Enya alluded to earlier on, most mothers, you find that they've never had a scan before, and this is their 4th pregnancy. And you're like, how is that possible that someone is able to, have so many children and not have quality antenatal? So antenatal is still pretty significantly poor, even if, part of the population are receiving it, which is some of the problems we want to address. And we have a lot of undiagnosed high-risk patients from things like low-lying placenta, which is what we call placenta previa medically, to things like anemia in pregnancy. These are some of the risk factors that can be intervened early on and correctly and to prevent complications setting in. But most patients go to delivery without that being done, and possibly explains why we still significantly have high mortality rates in our region. And one also issue of the current system or health system in Sub-Saharan Africa, Zambia to be specific, I don't know other setups, is you usually have your clinic or your hospital dedicating a single day in a week where they call it an antenatal week. So you find that that day might not be comfortable or flexible for every mother to come in, and also just generally how the attitude of the health workers is still a challenge. So those are some of the challenges that still exist, in these setups, which we're hoping to address, incorporating our model and innovative tools like the BabyChecker going forward. Next slide, please. So the solution we've built at Dawa Health over the last 2 years or so is an integrated, holistically approach to maternal health. So we have internally built a tool that helps us identify the necessary parameters when talking about maternal health. So it looks at things like past medical history, takes a look things like the observations that have been done, demographics, a number of things. And using that data, we're able to kind of predict potential risk. Then that goes on to the mobile clinic vans we have. So they go into the communities usually where you don't even have a local clinic, and we're able to partner with either local pharmacies or markets there. Then patients are coming into the mobile clinic for a comprehensive maternal, interventional support. So in the mobile clinic, that's where you have tools like the BabyChecker that are supplementing our internal house, a predictive platform. And with this, we're able to kind of give a comprehensive support to maternal health, identify high-risk patients. If they need early referral, we refer them to advanced centers where the appropriate intervention can be done. And we supplement this by a network of community health workers. So in the communities you operate in, you have local custodians who have the social capital, who are trusted, who've been in these communities for a very long time, that are able to mobilize patients to come in to access services at Dawa Health, making it useful, right? Because a tool like BabyChecker would need the patients to come in and seek the healthcare. But we see that in low and middle income countries, it's more than just the diagnostic tools, it's even the attitude and behaviors. So we're trying to also tap into that and, kind of champion people seeking healthcare early and getting the right healthcare, which has significantly, in our pilot over the last year, we've been working with BabyChecker, reduced the average first antenatal point of contact from about 6 months to between 1 month and 2 months, which makes a significant difference in us allowing us to support and identify potentially high-risk mothers in intervening time. Additionally, we've added on a hybrid pharmacy that enable us to retail things like your folic acid, vitamins that might be needed during pregnancy to supplement a mother, providing the right nutrition and, right oxygen to the baby. And lastly, we are also essentially incorporating last mile logistics. At the moment, we have a network of motorbikes that deliver these things to our community of workers. Next slide, please. So this is essentially just a summary of how the whole concept works at the moment. So we essentially onboard community healthcare workers who we then give training on how to mobilize the population, on how to essentially tell them about BabyChecker, the advantages it comes with, and the other tools we incorporated, and where they can find us through our mobile clinic vans, through our partner slum clinics as well. Then we're able to essentially do the needful triage and essentially support the mother accordingly and rightly. Next slide, please. So these are some of the tools we are currently using in our mobile clinic vans and in our model. So we are using the BabyChecker powered by Delft. So with this, we're able to potentially identify some of the high-risk mothers and we've been able to identify a number of them. And the outcome have been good because of that early detection. We've also additionally added a Gen II into our channels, which is WhatsApp, mobile app, and web. This allows mothers to access the right validated medical knowledge in their native language because it's able to do interpretation between languages. And we're able to also now do anemia detection, which is part of the tool I'll talk about in addition to Delft. That's essentially looking at the conjunctiva. Then it's able to approximate the hemoglobin levels and how that essentially help us manage patients who are potentially high risk, adding to what BabyChecker would be able to identify. Then we're also doing a predictive algorithm on our platform, which has been supported mainly by MIT Solve, which I talked about earlier on. Next slide, please. So I'll go into this case study. One of the interesting case study we recently had. So we operate in a number of slum communities in Zambia at the moment. And one of them is Ngombe, which is a significantly underdeveloped area, but with high population density. And you find that you have a lot of teenage pregnancies, you have a lot of high-risk pregnancies in that area. So we had a female 23-year-old who came. She was around 36 weeks, 3 days at the time. She had our first point of contact with our team. And we were able to essentially look at how big the superficial frontal height was, about 36 centimeters. We did the BP profile, which is around 128 to 78 millimeters of mercury, and pulse was around 82 beats per minute. So if you see, before we had incorporated BabyChecker, if you see such a patient, as a health worker, you'd assume everything is okay, and you'd send such a patient back home, not knowing that she's even a potentially high-risk patient. Then when she goes to her local clinic to deliver, you find that this patient would likely bleed on the table and potentially die. Why? Because their placenta is low. This is something as clinical or as health workers, we're not able to tell clinically. But with such a tool like BabyChecker, as you can see our team here using it, we were able to identify that this patient had a potentially low-lying placenta, which is what I said, placenta previa. So placenta previa, essentially, when the baby is coming out through the birth canal, they're essentially able to cause trauma to the placenta, which would cause excessive bleeding, and a patient can die from that bleeding. So you can see that with a tool like BabyChecker, we were able to pick that early on, and we were able to know that this is not a case you can manage at a low-level health clinic. So we referred this patient to a teaching hospital where they were able to be assisted, and the mother was able to be stabilized, and the baby was delivered, and the baby was okay. Up a score of 8/10 under the first minute, the 9/10 under 5 minutes. So you can significantly see how in the real world a tool like BabyChecker is actually making a difference, because we're able to identify some of these potentially high-risk patients who would otherwise maybe succumb to whatever undiagnosed conditions they have. And a tool like this would help in the management and early referrals and really make a difference in the last mile. You go on to the next slide. Yeah, so AI-powered non-invasive anemia detection tool, which is supplementing the work we're doing with BabyChecker. You will see that some of the patients who succumb to what we call postpartum hemorrhage is essentially any blood loss that happens during giving birth that would essentially lead to hemodynamic instability, or essentially someone going into shock, what we call medical shock. So you can see that a placenta like BabyChecker helps us identify before it happens. Then a tool like the non-invasive anemia detection enables us to identify the level of the blood in a patient before they actually go for delivery. So with this, we're able to see that about 80% of the patients in our early access pilot were anemic. So essentially they had blood levels that were lower than what we medically recommend. And when patients give birth, they're likely to go into shock. This might be even with placenta previa or with other conditions. So such a tool is helping us really comprehensively support a patient, that we might be able to see, okay, the low-lying placenta is not there in BabyChecker, but this is a patient who has low blood. So even if they give birth at their local clinic, there's minimum bleeding on giving birth regardless, right? So that can still cause a patient to go into shock. So these such tools that are AI are kind of comprehensively helping our clinicians in the last mile make the right clinical decision to say, okay, with this, we're able to refer this patient, we're not able to support such a patient. So that's how significantly AI is really making a difference in the last mile and making, a change in the communities we are operating in. You can go on to the next slide. Yeah, so this is essentially just going a bit into some of the research we've been doing in-house, some of it with Delft, some of it with other partners, which is essentially trying to just improve the AI long-term. So this table was just, we were doing a comparative analysis between, the non-invasive anemia detection tool and the standardized lab test to help us build into that data set, which eventually, have good clinical outcomes. So you can go on to the next slide. Yeah, so this statistical analysis was just essentially looking at some of the hypotheses we have to say, okay, where is AI at the moment, especially for the non-invasive anemia detection, comparing the mean differences between, the AI one and the lab standard, so that we continuously improve using the pictures we are capturing from, the smartphones or the non-invasive to make it significantly be good. So as you can see, I'll just summarize this. There's still more work that needs to be put in to make some of these tools really clinically significant, which is essentially what Delft also talked about, the research they're really doing on the ground to really make these tools validated and clinically significant so that they can be scaled to people who otherwise before didn't have any screening or diagnostic tools. Yeah, so this is just a summary of that. Next slide, please. Yeah, so this is essentially the question we've been asking ourselves internally. How can we really improve tools like the BabyChecker, tools like the NIADA, to really be at par with some of the clinical tools, and that can be scaled at large scale. So the recommendations we have decided to stand on with my team is we need more interventional studies or clinical trials, which we're already doing at Dawa Health, to really improve such tools that when they can be scaled, they'll be accessible to more people because they'll have validated work in such environments, in such setups. We've really also been looking at how can some of the model can be recalibrated. What are some of the challenges in making these tools be accurate or be at par with big expensive tools at the hospital setups. We've been also trying to look at bias analysis, which is a challenge with AI tools, of course. How can we reduce bias in terms of the data sets being built and collaborating with partners like Delft? We hope that would significantly improve, the data set to have, representative of, the population or the communities we are trying to scale these tools in. And also we are hoping to have explainability on how AI tools will understand some of the results and make a difference. So yeah, this is essentially, our recommendation as we are building in-house and also with different partners. You can go on to the next slide. Yeah, so this is the impact so far we've been able to currently have significantly in the communities through the partnerships we have with companies like Delft, with the BabyChecker and other partners as well. We've supported over 7,000 patients already, and we are significantly trying to scale this by end of 2025 to between 20,000 to 30,000, which will really make a difference in making such tools accessible, help reducing some of the complications like postpartum hemorrhage, things like preeclampsia and other things. Some of the things I touched upon them earlier on. I can go on to the next slide. So this is some of the testimonials we are getting from patients who have benefited from BabyChecker and the model we've essentially developed. So they're really loving the difference such scans make. So you find out that one way patients are now referring to Dawa Health is the place where you have multiple tests done. So they love the BabyChecker too. They're saying this is a really advanced tool. Why don't other facilities have them? So that's the kind of brand identity people are starting to identify us with, and the extension of our community healthcare workers. So you can really see people now being motivated to come in for antenatal checks, to come in for support and all that, which really at the end of the day will translate into the impact going forward. You can go on to the next slide. So essentially I'll ask, in case, of course, on the panel, there are people who want to partner with us to do collaborative research to improve continual testing, improving AI tools in low and middle income countries, and also partners who might want to support research, whether in terms of funding, in terms of expertise and all that. We're definitely hoping we can continue building this work, which will really make a significant difference in low and middle income countries in a couple of years when such tools are scaled at large and it's more accessible and making a difference in our communities. Next slide, please. Yeah, so essentially this is my team I've been working with over the last 2 to 4 years, helping us make some of the differences. I just wanted to appreciate them, that people see the amazing people who've been behind this work, and some of our research collaborators as well, who are helping us champion this work in the low and middle income countries like Zambia and Zimbabwe going forward. Next slide, please. Yeah, so in a summary, I think that's it. Thank you, everyone, for paying attention and listening to the work we're doing, working with Delft and trying to scale this work of maternal health and accessible AI in the last mile. Thank you so much.
Thank you, Dr. Munzwa. Dawa Health's work in Zambia is truly phenomenal. A kind reminder to all our audience members today, please make sure that you write your questions in the Q&A section so that our experts can answer it at the end of the webinar. Also, to all our speakers, we truly welcome you to this webinar. We would really like if you continue presenting like this. Now, I'd like to invite Dr. Ganda, Dr. Gregory Ganda. Dr. Ganda is the country executive committee member for medical services, public health, and sanitation at Kisumu County, Kenya. Today, he's going to be discussing how he and his team are leveraging AI ultrasound, risk flagging, and digital records for better outcomes in Kisumu County. The floor is yours, Dr. Ganda.
Very much, Katya. Probably move the next slide, the first slide. Thank you. I think that's me. I'll be talking to you about how we are leveraging on AI ultrasound, risk flagging, and digital health records for better health outcomes in Kisumu. My background is actually gynae oncology. I'm a gynecologist who's practiced gynae oncology and currently working in Kisumu. Next slide, please. I'm happy my colleague has talked greatly about this background, about the maternal deaths that are occurring globally, around 287,000. And he focused on the high percentage that is occurring in middle-income countries, basically the sub-Saharan Africa. And what we are saying is that 70% of them are actually driven by delays in care and resource limitations. So we in Kisumu are also in this journey. Kisumu is one of the counties in Kenya. Kenya has a devolved system of government. We have 47 county governments, and Kisumu is one of the counties along the lake. We are in Kisumu, our goal is to reduce maternal and newborn mortality by 80% by the year 2026. It's something that we've been doing over the last 6 years, and I'll be showing you the statistics so far. We've been able to do that by around 30% right now. And we want to pioneer evidence-based quality care for healthier moms and babies so that we enhance value-based care. Next slide, please. So in the background, this is Kisumu. We have 338 facilities, which is spread around dispensaries, health centers, and sub-county hospitals, usually in 4 levels. We have level 2 and 3, which is the dispensaries and health centers. And then we have level 4, which is the referral facilities, the primary referral facilities, and the level 5, which is the referral facilities for those level 4s, which is the higher, what we call them, county referral facilities. These are our indicators. If you look at 2014 and 2022, by the demographic health survey, I'm particularly going to look at health facility deliveries. At that time, we were doing, in 2014, we only had 69% of mothers delivering in facilities, actually 61%, based on the numbers. Those are two different numbers. There's the Oxford survey of 69.5%, but we were able to increase that to 94.4% by the year 2022. But if you look at lower down at the maternal mortality, we were able to reduce maternal mortality from 495 per 100,000 to 343 per 100,000. That is quite a big reduction of 30%. And the infant mortality and under 5 mortality is also reduced during this time. And the issue was that we were able to drive the numbers from the community come to the facilities. But if 94% of the people are delivering facilities and you have a maternal mortality of 343, it means then that you are not offering quality, and the quality that you're offering is not good enough. And probably you are not preventing as many maternal deaths as you should have been preventing. And that is where we are starting from in our next phase from 2022 up to the 2028. Next slide, please. So the issue is high burden of maternal and perinatal mortality that I've talked about. But the bigger issue is that we have poor access to quality services in the rural sub-counties. I would have shown you a different slide that shows you we have Kisumu as a center with a large referral hospital called Jaramogi Referral Hospital. And we have another one called Kisumu County Referral Hospital. You find that the percentage of deliveries that occurs in these two facilities in this sub-county is almost 150%. And that tells you that the number of people who attend antenatal clinic vis-a-vis those who deliver, many more deliver than those who attend antenatal clinic. Meaning then that we have women who travel from quite long distance to come and deliver in the facility. And why we think that is so is because the facilities which are in the peripheral typically are inadequately staffed, and they have inadequate skilled staff also. They have less numbers, but also the skills are less. And so what happens is that when mothers get poor outcomes in these facilities, they get discouraged because one mother tells the other, no, I think that place is not very good. And when they hear that there's a better facility, then they wait to travel to that facility. Sometimes they don't have transport. So the first thing that it causes the first delay, they cannot decide to go to the facility. Then after that, when they decide, now I think there's a problem, you have a long distance to travel, and all these things lead to poor outcomes and delays. And so what we want to do is make sure that whatever is going on in the peripheral facilities is quality. And go to the next slide. And this is our cycle that we think is going to happen. If you look at the top, I think the top of the circle, if we improve the quality of care at the primary healthcare facilities, two things will happen. One, these facilities will be able to detect who needs to be referred and who needs to be seen at a higher level facility because there are more complicated cases. But secondly, it will improve the patient's journeys and their outcomes. They'll feel that they have been well taken care of and they'll get a good outcome. And so they'll be happy. And when they're happy, it encourages more people to use the primary healthcare facility. And when that happens, the revenue for that health facility improves. And when they have more revenue, it means they can increase the investment in that facility to again improve the quality of care. And that cycle is what we are trying to break. Usually I say what comes first, the quality of the money, the investment before the quality, or the quality before the investment, whichever way you look at it. But the investment needs to be done for you to start seeing that improved quality. And that's what we want to do here in Kisumu. Next slide. So what's the ambition? If we digitally connect all these people, then we will be starting to solve our problems. We want to develop a digitally enabled infrastructure at all levels of care for quality maternal and child health for mothers in Kisumu, so that we never lose track of a mother and her baby throughout her journey. That means that we want to register you from the time before you even get pregnant to the time you get expectant, and know your journey, know what is going on, follow you up until you deliver, and follow up your baby until the baby finishes the immunizations. And what you want to do is leverage on technology, because we know the problems that I've talked about. Peripheral facilities have less people, they have less experience. How do we make that experience from the hospital go all the way down there without having to look for somebody who has experienced work down there, because we know all over the world, most people who are experienced want to earn more money and they want to live in the cities. Next slide. So how does AI come into this? One, we want to bridge the resource gaps through early detection, monitoring, and decision-making using AI. And what are we going to use? We are going to use electronic records for the mother and the child, because the first, for you to use AI, it means that you must have data. You must have information flowing in. So we want to have all the information flowing in. Whatever happens to the mother, whatever happens, whether in the community or in the facility, that has to go to an electronic record. Now, from that electronic record, then the AI can be able to flag those who are at risk or those who need to be referred, and actually sometimes advise the client, the mother or the health worker on what needs to be done. So we have two tools that we are currently piloting. We started this program, I think, 3 months, 6 months ago. One, we have the Wanda electronic medical records, which basically is going to do two things. One is going to collect all the information about the mother all the time, from antenatal clinic to delivery to postnatal to the mother. And what Wanda EMR has is that it has an inbuilt maternal early warning sign, meaning that whenever this information comes into the application, it can flag the people who are at risk and becomes an early warning sign for the clinician and for the mother. So that AI-enabled real-time alerts for those anomalies will be given to the facilities so that they're able to see. And there will be 3 bands. There's a red band, the yellow band, and then a green band. A green band means there's no problem, but a yellow means that there's something that needs to be checked. And the red band means that there's something that urgently has to be followed up. The second thing we're leveraging on is AI-enabled portable ultrasound for fetal maternal monitoring, and that we are using the Delft imaging ultrasound for that purpose. Next slide. I think I've talked about this. The Wanda EMR monitors mothers in the natal and postnatal changes and generates real-time alerts, red alert and yellow alert. Red for high-risk anomaly, that's a deviation from the normal, and yellow for mild to moderate risk anomaly. And the Delft BabyChecker is a portable AI ultrasound. We have put it in wards. Actually, when we have a county, I didn't explain to you how a county is in Kenya. A county is further divided into sub-counties, and sub-counties are further divided into wards. And a ward is a cohort of people. So we're piloting the BabyChecker in one of our wards for the last 1 month. And the first pilot really is not to look at the outcomes, but to get the change management, to let people understand what this thing is all about and let them incorporate it into their day-to-day work. We are hoping that in the next 1 month, once they're used to it, we will incorporate these findings into the EMR so that the information goes automatically. And so far, in the pilot, we've been able to do 103 scans. Next slide. This is basically a map of the area where we are piloting it, and we want to build on the infrastructure and the technology that already exists. One of the things that Kenya has moved towards is that Kenya has decided that primary healthcare is very, very important, and Kisumu is taking a lead in this. So we have formed what we call primary care networks, and primary care networks are facilities which are working together to take care of a population. And so in this area, you can see the facilities which have circles around them. That circle is actually the distance, around 2 to 3 kilometers from that center. And all those dots and pluses are facilities which are in that area. If you look on the left side of your slide is where we have your referral facilities. The largest referral facility is in GOTRH in red, and then KCRH down there in green. And so all the facilities on the right refer all their complicated cases to these 2 facilities. But we want the facilities, the bigger facilities, if you look at Geerts down there, St. Elizabeth, Chiga, and Nyalunya Health Center, which have pluses and big circles around them, to be like the sub-hubs where we can be able to take care of the population, and then they will serve the smaller facilities. Another thing we've done in this country, and I think my county was ahead in terms of digitizing a community health system, is that we have digitized our whole community health system and have an electronic community health information system where we register each and every household, and every household has a file, and we know how many mothers are there, how many children, how many men, and what is the living condition like. And these are the things that we want to leverage on in our system. Currently, we are, and our primary healthcare facilities are undergoing digitization, and we actually want to digitize reproductive health. We are starting with maternal and child health clinics in all these facilities that I've talked about into this system. And we also have the district health information system, and this is usually collected at the end of the month by our teams. Now, another thing you will notice is that some places have more facilities. If you look down there, Nyalunya, towards JTRH, because the population is higher, and these are the black places are mainly, most of them are private facilities. And so we are leveraging also on making sure the private facilities become part of this network, because they also see our mothers. Now, all this infrastructure that we built is what we want to leverage on to have AI enabled assistance to our people. Next slide. Next slide, please. Yes, so this is the pilot project so far, 6 months. We started from the 2 facilities I talked about, the referral facilities, because we needed to first of all find out if the EMR works, what do we need to add. We needed to look at the flagging, because once the EMR shows a flag, like a red flag, it straight away advises the healthcare worker what they're supposed to do based on the standards that are available in obstetrics and gynecology. So we have 8 facilities that we are scaling to as we speak. So far, we have scanned, or not scanned, we have seen 2,626 mothers in antenatal clinic since May 2024. And the high referral facilities where we started from, the Kisumu County Referral Hospital, had 1,508 visits. And the Railways Health Center is a smaller facility, has recorded 846 visits, and the rest of them have come from the peripheral facilities that I've talked about. Peripheral facilities just joined in, I think, around a month ago. We have red and yellow alerts guiding the interventions to be done. And we have started looking at the early detection using abnormal readings for terms of BP, fetal heart irregularities, and all those kind of things that come into the antenatal clinic, including your antenatal profile. All the information which goes into the EMR are actually used to develop an early warning sign. We are yet to start a community early warning site that actually looks at mothers, and whatever they ask, they're able to communicate with the facility directly. And there's some questions which, when you ask, are actually a red flag. That if you ask, I've seen some spotting and you're late into your pregnancy, that's a flag. So we are yet to incorporate the community information into this system. We have done community engagements at 2 of our facilities in Angola and Chiga so far within the last 1 month. Go ahead, next slide. So I note that we've used the POCAS for the last 1 month, and so far, from May to November, we are having almost 60 red alerts monthly. And what happens with these red alerts is that the facility is informed, but also we have the gynecologists at the main center who are informed at the same time. And what has happened is the ward practice groups have formed groups. When there's a red alert, it will be alerted and sent in the group. And you'll have to explain what you've done to that particular mother who's on a red alert. And if you didn't do, then there is somebody at the background, a gynecologist, who checks a day later to find out what happened to this mother. In terms of POCAS, we have started scaling this to underserved areas. If you looked at the last slide, the places that I've said are bigger facilities where we want to have the point of care ultrasound. And you realize the peripheral facilities sometimes have very low numbers. So it does not make sometimes economic sense to have one of those POCAS machines in a facility, because they might be seeing 2 mothers in antenatal every day. And that might not give you enough numbers. And so you need a machine that moves around. So what we are doing is that we are developing a system where the mothers can be booked for scan on certain days, so that every day we know where the AI ultrasound is, and the mothers get this done routinely in their clinics on their booked day. Next slide. So this is the slide showing the antenatal clinic from May 2024. So far, we have had 393 red alerts out of 2,200 and something visits that I showed you. But what I want you to note in this slide is that out of all this, we have not noted any fetal placental anomaly, even in the largest facility. And the fetal placental anomalies I'm talking about are multiple pregnancy, placenta previa, inadequate polyhydramnios, and all those anomalies which you usually see in the fetus or in the placenta. And that is why ultrasound is a very, very important component, because you might think even where there is high volume and you have an ultrasound and a sonographer who has been employed, it becomes very difficult for a mother to get booked to go to the ultrasound room. They get lost in between and they don't do the ultrasound. And so you can imagine that out of 2,200 people we saw, we are not able to flag a fetal placental anomaly that needs our attention. And again, on the other side, you look at the women or the caliber of people we are seeing, 60% are between 20 to 30 years of age, but we have a significant percentage of teenage pregnancies, almost 20% in these people that we have seen. And these numbers are even worse if we move to the peripheral facilities, where we have up to 40% of mothers being teenagers. Next slide. So what are the challenges? The challenges, one is distance to be covered for ultrasound sharing. We're trying to work out how we can look at the issues of transport for these mothers when they're going to this peripheral facility, or for the healthcare workers, which have low number of antenatal attendances. And I think I've talked about that. And the second thing is sometimes we have inconsistent internet connectivity, and that means that the information sometimes is not live. It has to be synchronized when the machine comes or our tools come into the space where there is internet. The biggest thing again is resistance to new technology amongst healthcare workers. People are used to the big old machines where you scan and you see a baby, and it takes time for you to change people's attitudes towards the technology. And there's also limited awareness of the patients on AI tools that actually you can just scan and then everything is given to you. And it is almost as accurate as a human being. Next slide. Next slide, please. So I'm not going to go through all these recommendations, but basically we need to be able to scale up the AI applications, extend monitoring to inpatient maternal care, incorporate predictive analytics for even postpartum complications. We need to do capacity building for healthcare workers, for the community on AI. We need to TikTok more. We need to have these webinars. In terms of policy, we need to look at increasing funding for sustainable AI interventions, because sometimes, even in my country, most people don't think AI intervention should be paid for. They think that you should see a human being for that to become a service that is paid for. Even though we know that the AI sometimes is just as good and will give you the quite good information. We need to be able to look at how we integrate the AI tools into the programs, strengthen our infrastructure, and establish robust data management systems that incorporates AI. Finally, next slide. Looking forward, we are championing AI integration in maternal health care systems. We want to support policies to sustain the funding for AI programs, and I think that's what I've been doing for the last 2 months. We want to promote multi-sectoral collaboration to scale and refine these tools, and prioritize training to ensure readiness for AI-driven healthcare, because that is the future. We can't run away from it. No mother or newborn should die from preventable causes in this day of this era. Thank you very much. Last slide. Thank you very much. I think that was my last slide, and I'll welcome any questions later on.
Thank you so much, Dr. Ganda, for your valuable insights on how AI can assist and definitely not replace humans. Please remember to put your questions in the Q&A section for all our experts to answer at the end of the webinar. Now, I'd like to invite the Program Director of the White Ribbon Alliance in Sierra Leone, Amie Koroma. Amie Koroma today will be discussing her knowledge and her insights into exploring experiences with smartphone AI in fetal ultrasound, a study from Tonkolili, Sierra Leone. Welcome, Amie.
Thank you very much, Katya. Hello, everyone. I am Amie Koroma. I work in maternal and child health care, And over the years, I have worked with various health stakeholders to understand the health needs of women and children in order to better plan for those needs. I recently studied at Royal Tropical Institute where I met Enya, and I came to know about the BabyChecker. I became interested in BabyChecker and decided to base my thesis study on it. Next slide, please. Next slide. Yeah. Do you know that in Sierra Leone, most healthcare workers would go through their medical training and have their entire career working in maternity without ever seeing an ultrasound scan, yet alone know how to use one? The same is true for most pregnant women. Most women in Sierra Leone have to go through multiple pregnancies and never have the opportunity to have not one pregnancy scanned. And this is sad because this is the reality of most healthcare workers and women in Sierra Leone. And there is definitely a need for innovative, cost-effective solutions in order to reduce these high mortality rates in Sierra Leone. Enya already mentioned the effectiveness of ultrasound and BabyChecker to be specific. And we know how it can identify risky pregnancies in order to reduce the maternal and child health outcomes. So the question is, will BabyChecker be one of those innovative solutions for Sierra Leone? Because we know its effectiveness, we know it works. But when you look at the Sierra Leone context, will BabyChecker work as effective as it is meant to be? Next slide, please. So a little bit of background of the pilots in Sierra Leone. So the BabyChecker was piloted in Sierra Leone, Tonkolili district since 2022, and it was integrated in routine antenatal care visits where free scans were provided to pregnant women. And based on the results of the BabyChecker, the pregnant women were either managed at the primary health care or referred to a secondary care for further care. So my study objectives was to explore the adoption and sustainability of AI fetal ultrasound scan, or specifically BabyChecker in Sierra Leone. And mainly we want to look at the knowledge and awareness around ultrasounds in general, but also looking at what are the barriers and influencers to implementing not just BabyChecker, but related AI-related devices in Sierra Leone. I spoke with healthcare workers and clients as participants, and I actually went to Tonkolili district and collected the data myself through key informant interviews with the senior staff from the Ministry of Health and Sanitation and also from the hospitals. I also spoke with the frontline workers who were using the devices themselves. And of course, I also met with clients, that is pregnant women and lactating mothers who underwent the scans in these facilities. As part of my study, I used the NAS framework to actually put up the objectives and also to analyze some of the data. Next slide, please. So what do we find out? So as part of the description of participants, I find out that most of the healthcare workers in Sierra Leone are women. So 90% of the health workforce is dominated by women, but unfortunately, these women are in the lower cadre, and also most of them have low background, educational background. Next slide, please. So these are the key findings. So when it comes to the knowledge and awareness of the BabyChecker, all of the participants interviewed mentioned that indeed the device identifies risky pregnancies. And when it comes specifically to the clients, we're able to say that when we go to the healthcare facility, most of the healthcare workers will scan us and they will tell us whether or not our babies inside our belly are doing well or not. So you can see that they are aware of the BabyChecker's importance and they have to have their pregnancy scanned. When we look at the technology, the device itself being used, the user interface by healthcare workers, most of the healthcare workers, in fact, all of them said that the device was easy to use, mainly because of the visual guidance. The video indexed in the BabyChecker helped them to actually go through the pregnancy scan step by step, and they were able to self-train. One of the key aspects they also highlight about the BabyChecker was the traffic light system that is inbuilt in it that aids prompt referral. For instance, the BabyChecker will tell them whether or not they have to refer a pregnant woman or not. So as you can see, one of the healthcare workers mentioned that we realized that the scan helps us to reduce, for example, time spent on listening for a fetal heartbeat and determining the gestational period, which is difficult to do manually. We all know that human beings, we are great at doing things, but most times also we are not perfect. So, but with the technology, with the aid of the BabyChecker, they were able to actually identify some of these things. Next slide, please. So when it comes to perceived value, all of the healthcare workers and the clients mentioned that there is every need for the BabyChecker to be in their community, because for once, the pregnant women are coming for scans and they are strengthening other ANC services. So it increases ANC attendance. So women really appreciate the scans because it's proving to be effective. Also, it offers high diagnostic accuracy. So for instance, one of the pregnant women has to say, we even trust the device more than the healthcare workers because the errors are limited. So another client mentioned that many women have died or experienced stillbirth without knowing it before the BabyChecker gets to their communities and facilities. So indeed, they perceived it as having a high value. When it comes to adopters, they also mentioned because of the user-friendliness of the device, it was easy for them to adopt it within their routine work. So one thing I also find out is that technology is easy for healthcare workers to adapt if it can be easily integrated in their work. If it's a high burden, if it requires them to have on new documentation or new work to be done, it's difficult for them to have it adopted. So they said because of the user-friendliness of the device with clear instructions, it was easy for them to actually implement this device in their facilities. They also mentioned as part of adopting that the challenges, including limited resources, for instance, they need examination bed so that they can use it to scan women. But in most of these healthcare facilities, you can only find one bed. Usually it's an admission bed that they will use to scan women. So they're struggling with this. So they mentioned that even though the BabyChecker device is good, it's working effectively for them, they need other facilities in their healthcare so that they can perform well overall. Next slide, please. So when it comes to organizational system, we see clearly the role of health system. So the weak health system in Sierra Leone comes out clearly because if you can identify a pregnant woman of having a particular issue, then you need to refer that woman to a secondary facility or tertiary facility. You then need something like an ambulance, or you need maybe medical drugs facility at the facility, but most of these things are not available. As you can see from a key informant that the reliability in Sierra Leone for proper procurement and restocking of accessories is the key problem. So this means that the weak healthcare system in Sierra Leone has an impact on any technology device being implemented. When you look at the wider system factors, we talk about policy and infrastructure gaps. So Sierra Leone does not have any policy that talks about high devices, technology-based devices or imaging devices can be used and implemented in the country. And also we are looking about infrastructures in terms of electricity, internet facilities. So as you can see, most of the healthcare workers did not mention internet or electricity as a problem, not because it's not an actual problem, but because most of these facilities we are provided electricity or solar powers by partners, so it was easy for them. But if you look at the rest of the country, electricity is a problem, access to internet as well as data is also a problem. So the issue of corruption also came out clearly because as stated by one participant, saying that payment is also discriminatory. Some women are asked to pay while some don't pay anything for the same services. If you don't pay this money, you will not be scanned. They will tell you that the device is not available or not charged, and they will refer us to ILE, meaning the secondary referral hospital, even when we don't need to be referred. So as you can see, most of these issues affects the effective implementation of the device. And also generally the poor background, the general socioeconomic barriers hinder women from also coming to the facilities, mainly because if they come and if the healthcare workers tell them that this is the diagnosis, but then if we don't have drugs in place, if we don't have referral structures in place, then it's difficult for them to come again. Next slide, please. So when we talk about embedding over time, we're talking about sustainability, and generally we're talking about in Sierra Leone, there is very low digital literacy, and there are funding challenges that limit this. So as one of the participants mentioned, is that allocating the budget is okay, but then yearly subscription fee adds to the sustainability concern. This was discussed by a senior member of the ministry, saying that the device works effectively. I've seen it, and we'll be able to lobby with the local government to pay for some of the devices. But then when you consider the yearly subscription of the BabyChecker device, then that's where the real sustainable concerns arise. So outside of the nurse domain, another key area that emerged was quality of care. So what I observed mainly is that the shortened ANC time, but issues with privacy and counseling during scans. So women do not spend more time at the health facilities, mainly because the healthcare workers now have this diagnosis tool to help them with their diagnosis. But then we find out that they lack time to counsel pregnant women, and they also do not give them the proper privacy, the proper education they need before they are scanned. And also if they are scanned, most times they do not give them the results of the scan, except when they need to be referred, and they will just tell them that you need to go to the referral hospital for further care, and that's it. But one key thing that came out was the high community acceptance. Women love the BabyChecker. They love to be scanned. They are coming all the time, and they're coming earlier, which is very good because then they can also be assessed for other ANC issues. So there are no sociocultural issues and high community acceptance. Next slide, please. So in conclusion, the BabyChecker is effective in the area that is actually enhances risk identification and ANC attendance, which is what we needed at especially the first trimester stage. It also facilitates task shifting because all the healthcare workers were able to actually implement and use BabyChecker effectively, but then we need to look at the gaps in terms of holistic care. Also, I mentioned that there is need for clear guidelines and consistent supplies to ensure quality integration. And over-reliance on the technology risks diminishing manual care skill. Because one thing I also mentioned, one of the participants mentioned that we are using the BabyChecker effectively now that we are losing our skills, and they are failing to understand the complementary of the device instead of taking over their routine rules. Next slide, please. So finally, what are the implications for implementation? So we need to ensure that we educate healthcare workers that technology is there to complement their existing knowledge and capacity, and not to overtake the routine maternal and child health care skills and services they should be providing. Definitely, there is need to address the digital divide because there are infrastructural issues in terms of electricity, in terms of network and data in Sierra Leone. So these things goes beyond just the Ministry of Health, but also to other partners as well. There is need to invest more in funding and also in the infrastructure. There is need to strengthen the collaboration and research. And definitely there is need to refine the technology, BabyChecker, to fit the context of Sierra Leone, mainly with regards to the internet services, which is required to upload and download scans sometimes. So that's it. Thank you very much.
Thank you so much, Amie. Yeah, your study has been really insightful for all of us here at Delft and for our audience as well. Last but not the least, I'd like to invite my colleague, Julio Lopez. As Delft Imaging's head of ultrasound, he will dive deep into the heart of BabyChecker, which is the AI. The floor is all yours, Julio.
Thank you very much, Katya. Well, first of all, let's start that it is not only about having the best publication. It's more about bringing the artificial intelligence to the world, like to really tackle the problems, bringing it offline and making it available in a phone. So the people that actually need to use it can use it correctly. So I had the opportunity since I joined the company to travel around and see how the artificial intelligence is actually being used. And it's really nice to see here today some of the people that I met. For example, Tafa in Zambia, I was able to see how they were using BabyChecker in Dawa Health. I was able to also see during last week, I was in Sierra Leone, so I got to visit Ile, which is the place where we currently are using BabyChecker, and understand how the artificial intelligence is used, and not only the artificial intelligence, but also the overarching setting that we have. So the whole phone, how they were transporting the phones, how they were transporting the case, understanding the setting. And that's something really important that I think sometimes artificial intelligence or deep learning engineers, we forget that behind the data, there is actual people in the case of medical imaging. And it's really enlightening to be able to see that and do better artificial intelligence by understanding the real problems and how to tackle them. So if we go to the next slide, currently, the next one. Currently, BabyChecker is able to detect gestational age, fetal presentation, placenta localization, and multiple pregnancies. We have been working into that for already some time, and we are happy to say that the gestational age that we are able to get, we have a mean absolute error of 6 days. So that means that we are 6 days difference in average from an actual sonographer or obstetrician. The fetal presentation has an accuracy of 98% in the third trimester, which is when it can actually be a risk. And the placenta location has an accuracy of 90% in the overall data. And the multiple pregnancies, which is the latest thing that we have implemented, we are still validating with the data. Soon to be integrated, we will have the amniotic fluid volume, stillbirth, and we have a lot of things that we are interested into to do research on. And that's where it's important to find these collaborations and understanding and have these conversations with the doctors and the sonographers to understand which are the relevant things that need to be researched, the things that are actually going to be used in the settings where we are, and which things can actually be, what can we do about them? So that's really important. Like if we continue to the next slide. At the moment, as I was saying, it's not about having the best publication. We had our first publication that made us the first one tackling into the maternal antenatal care sector. It was in 2018. So if you click on next again, you will see the publications appearing. So we have like the first publications actually happened like back in 2018. And that made us really into bringing it offline and trying to understand which the settings were. Like from that point, we started doing more publications. And then in the next slide, this year, for example, we were able to present in the MICAI conference, which is a really important medical imaging conference for artificial intelligence, where actually it was Radboud presenting in collaboration with us. And it was presented as the most practical application of artificial intelligence and the most relevant and clinically effective workshop that it was happening. So in this case, what we did, it was for detecting fetal growth restrictions using abdominal circumferences. If we continue to the next slide. Now, the BabyChecker platform, like we have tackled over this whole webinar about the problem, what is actually happening and how can we solve it. In this case, it's with the artificial intelligence and the BabyChecker itself. So in this case, what we have done is over the last years of research and understanding, we have worked into creating this application that it's actually easy to understand, that from the research that we have seen so far, it actually can be used and can be understood in the settings where it needs to be understood, which is like these low and middle income countries where the access to internet is limited, where the electricity is limited, and the ability to do that, we can do that with BabyChecker currently. Like with only the phone charge, you can connect the probe to the phone. The probe doesn't require extra battery. You are able to perform scans. And this, for example, in Chile, in the antenatal care day, like you can easily scan 40, 50 belly women without any issue, getting the artificial intelligence results within 2-3 seconds of finishing a scan. This is all offline. This is all in the phone and can be done. It's already happening. It's already happening in Sierra Leone. It's already happening in Ghana. It's already happening in Zambia with Tafa using it, for example. So it's something that it's already there and we made it possible, and it's all possible thanks to also our partners and the people that has trusted us during the last years. If we continue to the next slide. This is also something I saw several questions talking about that. I think it's really important and it's something that we have been working during the last few months, is the BabyChecker dashboard. So we have collected a lot of data about how BabyChecker is actually being used, how many scans, how many risky scans are detected, the average performance per user, because of course it's a blind protocol. So we need to also be able to understand how the users are performing the protocol and if they are doing it correctly, how many rescans have been, how many fourth visits have been. So all this information is currently available in the BabyChecker dashboard that will be available during the next quarter. It's already having the last touches to finish it. And this will allow to establish and improve the organization systems for gathering, analyzing, and reporting key health indicators. It will reinforce underlying health structures using BabyChecker, and it will allow also to have more evidence-based decision-making in the product. This is something that we currently are able, like imagine in Chile, which is a rural area in Sierra Leone, like they will already have this digitalized data that can be, for example, then from this platform that we are building, it can be used in other platforms like the public health platform in Sierra Leone. Now they have the press track that they just showed around. So it's something that it can be used and it can be integrated. And the same way that we are integrating, like we can also use the dashboard in a way that it can really help implementation in places and digitalization in places where it's really complicated. So currently this will be available during the next quarter. So like it will be available probably around February next year. And yeah, it's gonna be something really nice because currently what we are doing is sending the reports, which are something that it's really usable and really valuable already. But this will allow to really have a most holistic overview of the whole product and how much good artificial intelligence and BabyChecker is actually doing, which is the main thing. So for me, the takeaways from the artificial intelligence and the product is that we have been working really hard to not only in the publications, which of course are also important, but also into making it a real product that it's already being used in so many places and that it can really empower the health workers in the places where they are really needed, like in the peripheral community centers, in those places that it's important to have these tools. And we are seeing that it's really helping. And yeah, I'm really happy to see how the future will bring more new research, new features, and new things to BabyChecker. So, of course, I want to thank again all our partners, like the people that I have met so far in the trips, like that I've been, and I hope to bring something more deep learning engineers to the field so we can understand and we can work in using better the data and really understand the setting and the places where we are doing this and why we are doing this overall. Thank you very much.
Thank you so much, Julio. This was really insightful and really fascinating to see where BabyChecker can go and how. I'm sure all of our audience is very curious and full of questions, much like me. So now I would like to invite my colleague, Florent, who will be tackling all of those in the Q&A session. Florent, please take it away.
Yes, thank you, Katya, and thanks for everybody for joining, of course, today. We had quite a number of questions. We're already going a bit over time, but that's good because then at least we were able to hear most of our speakers. What I'm going to do is pick out a couple of questions that I think that I found quite interesting, that I think would be good to answer also live. I believe all of the questions have been answered for people also in the chat, and be assured that we'll give you a Q&A sheet after the call, so everybody will receive that. So firstly, I wanted to touch upon a question raised by Marlene, who says that great to have technology incorporated in pregnancy care and to pilot projects and do case studies that result in great reports. The challenge is the integration in health systems. Is there any evidence of survival of the project after the end of the pilot project? Perhaps, Enya, you can comment on that a little bit. I saw you already responded to it, but perhaps also live.
Yes, we saw a few questions like that, which is, of course, really important. It's really important that BabyChecker exists beyond the actual BabyChecker solution,
Enya?
like the app.
Can't hear or see you.
I can't see. Can you hear me?
Fortunately, it be an audio error, but let me then just bring up also the answer here, and perhaps we get it up and running in parallel, but then I also read it. So it was also mentioned in the Q&A, and you mentioned the objective is definitely for BabyChecker to be integrated as an ANC tool, and therefore also in health systems used locally. Currently, not many of the partners and clients that we have such digitized health systems, unfortunately. So we provide a dashboard where stakeholders can access data about the BabyChecker scan, such as the quantity, quality, results, and rates of total attendance, attendance per pregnancy, and attendance per trimester. And I think Julio also touched upon this. When partners have digitized health systems for BabyChecker to integrate to, we'll be more than glad to collaborate to make ANC and data more holistic. Delft Imaging has a lot of experience in integrations, for example, with TB being integrated in the Kenyan surveillance system of TB. And I think you're already up and running again. I don't know if there's anything else you wanted to add to that.
Can you hear me?
Hey, Enya, we can hear you. Please go ahead.
Okay, perfect. Yeah, well, Florent, you covered all the bases basically, and yeah, I was glad to type all the responses in the Q&A. I think we got a few questions about that. It's really important for us that what we're building exists beyond just the BabyChecker app, that we're contributing to making digitized antenatal care data more available to key stakeholders in countries. There's not many countries or many partners we currently work with that have functional digitized health systems or monitoring systems. So that's why we built the dashboard, which is, of course, what my response also mentioned, to really help, make some way into the digitization and the usage of the data produced by BabyChecker. And then once we have monitoring systems that are available to our partners, so built by, let's say, the Ministry of Health or its partners, we will be glad to integrate into those. So, of course, put all the data, the very valuable data that BabyChecker is currently producing, into that system.
Great, thank you for that. And I think another interesting question that was raised was from Heidi in touching upon how will LMICs fund and scale up using countrywide these types of innovations. This is something you touched upon. Perhaps you can go first, and I see Dr. Ganda also responded to it. I don't know, perhaps you want to go first, Enya, and then after you, then Dr. Ganda can maybe touch upon it further.
Yes, sure. This was Heidi's.
Exactly, yeah. Heidi's question.
Yes, so far we don't have any projects that have scaled up to counties or districts or nationwide. So we're still, let's say, in the early stages of the deployment of BabyChecker beyond its pilot phases. Of course, that's what we have to be working towards to really make this sustainable. So far, the main payers are NGOs, small to large NGOs that either have donors or attract grants to actually purchase the BabyCheckers, but of course to make it more sustainable and scalable in those targeted countries, in LMICs, we'll need the Ministry of Health and their partners to help us scale that up.
Thank you. I don't know, Dr. Ganda, I saw you responded also to the question. I don't know if you maybe want to touch upon it further live.
Yes, thank you very much. I think that's a good question that was asked. The scaling really also depends on the funding models. For example, how do you want to fund your primary healthcare? In Kenya, we have said we want to fund it through a capitation model. That means that per capita, for every person, there's a certain amount of money which is set aside for their healthcare. And so it really bears upon the people who are offering the health services to decide what are these important things that need to be done in terms of the primary healthcare system or in terms of the antenatal profile of treatment that can fit into this. And that's what we're trying to explore in Kisumu and say that, can we at least have 2 ultrasounds per woman during her pregnancy? Because then we can be able to fit and say that it's around 600 shillings for 2 ultrasounds. And how can we fit it in this so that it pays for itself? Because otherwise the mother would still have to pay for it if she does it somewhere else. So those are the kind of funding models that we're looking into. For Kenya, we're looking at the primary healthcare capitation model and how it can take care of this. Thank you.
Thank you for that, Dr. Ganda. I think that's a very good point. I think that's also one of the things that I maybe also wanted to comment on from Delft side, that what I mentioned in my presentation earlier from Delft as an organization, we also try to see, okay, what's the health problem? How can we tackle this with technology? And then be creative enough together with our partners to find the right models to figure out indeed the financing component of it, which is of course a very critical one for the scale up. But this is also definitely something where we want to work with partners to see if we can, how we can best approach that and to make that work, because that might also change, of course, indeed per country setting. We've already gone 15 minutes over time, so I'm sorry I didn't get to all of the questions. Like I said, everybody will receive the Q&A sheet later on, so you'll definitely get that. There were some questions about will we get the recording. Those will also be shared with you, with those also in the different languages for everybody. If you have any questions at all, definitely make sure to reach out to us after that. And I think after that, thanks again to all of the speakers. My compliments to them and my gratitude for joining, and for all of those attending still online today. Sorry again, we went a bit over time, but hopefully the webinar was useful for everybody. And with that, I'll bring today's webinars to a close, and we look forward to continue to working with all of you to scale up BabyChecker and its efforts further. Thank you, everybody. Have a good day.
Thank you, everyone. Thanks for coming.
Bye.
Bye.
Bye.